Hello, everyone. Thank you for joining us today. This is a webinar on sensorineural hearing loss, Lassa fever disease, and vaccines. We have a disclaimer that's on the screen right now, just to let you know that this webinar is going to be recorded and we will make it publicly available. The audience members will be muted during the discussion. Please use the Q&A box, not the chat. Use the Q&A box for questions. We will try and reserve at least 5 minutes at the end of each of the presentations for a question and answer session. Thanks very much. Pia, next slide, please. I wanted to give you a little bit of context for the webinar today, just to set the stage, and then I'll be introducing the speakers and reviewing the agenda. Lassa fever is an endemic disease in West Africa with cases that occur throughout the year, peaks being November through May. Studies in sub-Saharan Africa suggest that about 37.7 million people in 14 West African countries are at risk of infection, with an estimated 5,000 to 60,000 deaths annually. Sudden onset sensorineural hearing loss occurs in approximately 30% of patients, with no clear indication as of yet to whether it's due to direct viral toxicity or to immune responses. Lassa vaccines are in development and will be tested in large-scale trials in the near future. SPEAC is working with developers to plan for such late-stage trials in children and adults in West Africa with thousands of participants. We felt as SPEAC that a review of what is known about sensorineural hearing loss following Lassa infection, methods for detecting hearing loss, insights from prior clinical trials and from the animal models will inform the design of these trials and provide suggestions for a standardized way to evaluate hearing loss that may occur during the studies. Next slide, please. Here is our agenda for today. I hope we can at least catch up a little bit with this. I'd like to introduce our speakers. First, we will be hearing from Dr. Faustina Blackie, who is a consultant ENT surgeon and the lead for sensorineural hearing loss in Lassa patients at the Irua Specialist Teaching Hospital in Nigeria. And she's the ENT lead in that country for the ENABLE study. Next, we will be hearing from Carmen Brewer. She's the former chief research audiologist in the audiology unit at the National Institute of Deafness and Other Communication Disorders. Following that, we'll hear a little bit about our Brighton case definition from Flor Munoz, who's a pediatric infectious disease physician at Texas Children's Hospital. And she's also the Brighton Collaboration case definition lead. Following that, we'll hear from two developers. Gideon Akintunde is the Director of Clinical Development at Emergent, and Pat Fast, the Senior Technical Advisor and Chief Medical Officer at IAVI. We will follow that by Slobodan Pesler from Galveston. He's the Director of the Galveston National Laboratory of Preclinical Studies Corps, the Director of Animal Biosafety Level 3 Institute for Human Infections and Immunity, and a member of the Center for Biodefense and Emerging Infectious Diseases. Unfortunately, what we had hoped would be our next speaker on non-human primate models yesterday informed us that she was not going to be able to join us, so we will miss that presentation. Then I hope we'll have time for a brief break, and then Professor Paul-Henri Lambert and Daniel Pinschuer will be discussing what we know as a summary from the animal models. Professor Lambert was with the Center of Vaccinology in the Department of Pathology and Immunology at the University of Geneva. He is the director of the International Advanced Course of Vaccinology, better known as ADVAC. And Professor Pinchuer is professor of virology at the University of Basel and an arena virologist. We finally then will have our roundtable group discussion for 45 minutes. We've taken the time from the non-human primate talk and put it into our roundtable. In addition to Professors Lambert and Pinchuer, we will hear from Dr. Karina Top, who's in Alberta, Canada, principal investigator of the Canadian Immunization Research Network Special Immunization Clinic, and she's the lead for the Incest Project. Joining her also will be Paul Olu from SPEAC, where he is the clinical development lead for the Lassa project. From Sylvanus Okogbinin from Nigeria, he is currently the chairman of the technical working group at the Institute of Viral Hemorrhagic Fevers and Emerging Pathogens in Nigeria. He is the former chief medical director for the Arua Specialist Teaching Hospital. And finally, in addition, we will have Nicholas Reed, who's an assistant professor of epidemiology with a joint appointment with ENT at Johns Hopkins. And he's also the director of audiology at the Cochlear Center for Hearing and Public Health. Carmen Brewer will be joining them as well. Steve Black will be moderating that discussion. Steve is my colleague at SPEAC and has more than 30 years of vaccine clinical trial and vaccine safety study experience, and works with me as co-lead for the DSMB project for SPEAC. Lastly, we will have a closing remark from Rebecca Chandler. Rebecca is the clinical development vaccine safety lead at CEPI, the former senior pharmacovigilance expert at the Uppsala Monitoring Center. And with that, I hope we can begin. Dr. Blackie, are you with us?
Yes, I am.
Great, thank you so much. Please
Thank
go
you.
ahead.
Yeah. Okay, we'll be talking about epidemiology and all that we know about epidemiology in Lassa of sensorineural hearing loss from Lassa fever. Next slide. Now, Lassa fever is a viral hemorrhagic fever, like we all know, and it has some sequelae, neurological sequelae, which is of utmost importance to this our presentation. Next slide. Next slide. Okay. Now, with respect to the epidemiology in West African region, some studies have been done, some work has been done, like in 1972 in the north, the White had a study showed that 4 out of the 23 patients that suffered Lassa fever came down with hearing loss. Mertens in Liberia had another high incidence that 30% of the patients with Lassa fever had hearing loss. And Ibekwe et al. In 2011 showed that 13.5% incidence of hearing loss in those that have Lassa fever. Next slide. While in Sierra Leone, SNHL in 2020 had another high incidence, about 17%, and Cummins et al., about 29% of people with Lassa fever who came down with hearing loss. Next slide. SNHL found out that there were no reports of hearing loss in those who suffered Lassa fever in southern Nigeria. While again in Sierra Leone, in 2018, there was 16% incidence of hearing loss from Lassa fever. But these two studies, SNHL and Lee et al., it was a self-report. The patients who report themselves, they ask, do you have hearing loss? They say no. So these are the incidents that they got. SNHL didn't get any. So next slide. Now, hearing loss is a disability which reduces the quality of life. Like we all know, it has been identified as the second leading cause of years lived with disability. And managing it is actually really a challenge because we really don't have a treatment per se, a cure per se for those that come down with sensorineural hearing loss. Even when we follow them up for a while, they still have this residual hearing loss that following Lassa fever. Next slide. Now, hearing assessment is it's a requirement because if we do self-reports, some people that have maybe mild to moderate hearing loss will not tell you that they have hearing loss. But when you do a hearing assessment, probably like a Pearson audiometry or something better, you actually have more cases of hearing losses from Lassa fever. And then coupled with the fact that some people with subclinical viral infections come down with hearing loss. So such people may be missed if we don't do a routine hearing assessment for Lassa fever patients. Next slide. So as such, even now, because we have this entity we call idiopathic sensorineural hearing loss in ENT. We say it's idiopathic, we don't know why it happened. Who knows, it may have just been from Lassa fever. From Lassa fever virus infection, Lassa virus infection, sorry. Next slide. Now we have a work that we are doing in ISTH. So I have a team that I'm working with, and we saw 43 confirmed Lassa fever cases. And out of these 43, 65% of them were male, 15% were 65% was female, were females, and 15% were male. Now, it was both adults and children. We have more adults, 27, making 62.8%, while 16 of them were children. Next slide. Now, hearing loss of varying severity and types were seen in 31 of the 43 participants, giving us a total of 72.1% hearing loss, which is quite high. Now, sensorineural hearing loss was seen in 48% of the participants, and conductive hearing loss was seen in 20%, 29.9%, while one of them had a mixed hearing loss. Now, of the 10 people had a normal hearing. However, 4 out of these 10 had high frequency losses. Next slide. Now, the 21 of the 21 patients with sensorineural hearing loss, 33 of them had unilateral hearing loss, while 33% had unilateral hearing loss, while 66.7% had bilateral sensorineural hearing losses. Next slide. Now, for the enabled study, we saw 23 participants. They were enrolled. We had 78.3% of the 23 participants coming down with varying degrees, varying types and severity of hearing loss. And we followed for 4 months. By the end of 4 months, 10 of them had residual hearing loss, and they were mainly sensorineural. Next slide. Now, of the 23 participants, 8 were children, 15 were adults. Sensorineural hearing loss was seen in 8 of them, giving 34.8%, while conductive hearing loss was seen in 8, giving again 34.8%. However, 2 had mixed hearing loss. And by the end of 4 months follow-up, 7 of the children with conductive hearing loss had normal hearing, while one of the children who had normal hearing at the beginning came down with sensorineural hearing loss. Next slide. Now, one adult with normal hearing, during follow-up, we found out that the adult had sensorineural hearing loss. Now, all the other participants with sensorineural hearing loss persisted through the 4 months follow-up. Next slide. Now, this is like a table of, like a chart of what we had at time 1. Probably you see it in the next slide because the next slide has a table. Next slide is a table. Now, at T1, that's on admission, we had the hearing losses that we see displayed there. 8 sensorineural, 8 conductive, and 2 mixed hearing loss. Now, the conductive hearing loss at time 2, T2, all had resolved, while one of these conductive hearing loss became sensorineural, making a total of 9 persistent sensorineural hearing loss. And then one of the mixed hearing loss got better. So we had 1 mixed hearing loss left. Next slide. And from literature available, there's currently no effective specific treatment that is available for the sensorineural hearing loss that we find in patients that have Lassa fever. The only thing we have now is that some of them resolve spontaneously. And the same was found out in 1990 by Cummins et al. Next slide. Now, from what I find, we have some questions that we couldn't answer. What really goes on in the ear? Because some people get better, others don't. Not everybody that have Lassa fever come down with hearing loss. And if it is an immune-mediated problem, why will some people have unilateral hearing loss and some will have bilateral? If it is inflammatory, it will go the same way with the immune-mediated response. So, and some other studies, I looked through the literatures, some thought it's the severity of the disease. But however, in studies that we have been doing here, we found that some people that even have severe disease, that even had to go through dialysis and all, some of them didn't come down with hearing loss, while some did. So why do some get better and others don't? So these are the questions that are seeking for answers. Next slide. So hearing loss remains a big challenge in Lassa fever. More studies are required, more examination, particularly of the inner ear, to be able to know what is really happening in the inner ear, because it's when we know how it happens that we'll be able to know how to halt it or how to stop it. Next slide. Thank you for listening.
Thank you very much for that, Dr. Blackie. I don't see any questions right now in the Q&A box. If members of the audience have questions, please put them there. That would be most appreciated. Dr. Blackie, perhaps I can ask a question here. Are you planning further follow-up of those individuals beyond the 4-month time point?
Well, not really, because following them up is actually a very tedious task. Some of them wouldn't want to come back. Probably if I start another study, I would cancel. First and foremost, we actually cancel them that we will follow for 4 months. I didn't take consent for more than 4 months. So if I do another study, I would want to see if I could follow for more than 4 months. But then again, I have some patients that come to the clinic that have been that have had hearing loss from Lassa fever. I've seen a few for over 2 years, and they still cannot hear. So I really don't know if following them further, I'll be able to achieve anything, but I could give it a try.
I can see in the chat that the panelists are having trouble getting their questions, or they're unable to put questions in the Q&A box. So if we could perhaps get a fix for that, Pia, that would be great. In the meantime, Dr. Manu Chaudhary had entered a question. Can you share more details about the conductive hearing loss in children?
Okay.
And was this hearing loss mostly in the children rather than in the adults?
Well, I actually, when I saw that, I was like, okay, I really don't know why it happened like that. But then again, I looked at the clinical presentation of patients with Lassa fever. There is pharyngitis for some patients with Lassa fever. So probably that could have been, by extension, there's pharyngitis. There is inflammation of the eustachian tube. So there is fluid in the middle ear from the pharyngitis which they have with eustachian tube blockage, which culminates into fluid in the middle ear. But a few of them had eustachian tube dysfunction rather than fluid in the middle ear. So I've not been really able to know why it happened like that, but I thought probably because of the pharyngitis.
Thank you. Dr. Pessler had a question. How many hospitalized Lassa cases do you have in Nigeria per year?
Per year, I don't have that information immediately.
Lassa number of cases.
Oh, per year. Let me ask Dr. Kogbeni. Dr. Kogbeni may have that. Professor Kogbeni may have that.
That's okay. Dr. Brewer had a question also. What is the timing of hearing loss relative to the Lassa fever?
Okay. What I saw is the degree of hearing loss. The timing of, can you take the question again, please?
Yeah, she was just wondering, when does the hearing loss happen in the course of the Lassa fever infection?
Okay, well, some of them happened during the acute phase. And the acute phase is actually defined by studies that I've seen within 21 days of the infection. So some of them occurred during that first 21 days. And then a few others occurred during the follow-up.
Thank you.
So we cannot really define per se to say that hearing loss will start at this point or at this other point, or that's so.
All right. Just one last question then. In the setting, this is from Stephen Obaro. In a setting where most children with otitis and bacterial meningitis are poorly diagnosed, it might be difficult to attribute causality. Were these patients screened for other potential causes of hearing loss?
Well, not really. They weren't, but they were well before they had fever and were screened, and they came down with Lassa fever. So in the history, I tried to ask, was this child ill before now? They said no, that she just had fever. Some of them, he or she just had fever. They thought it was malaria. And because it is in the, because they were followed up, it was in the study group for the enabled study. So that period too, we were able to identify and say, okay, you didn't have any illness before the fever came up. So by inference, we think it's Lassa fever because there were no other complaints.
Well, thank you very much again, Dr. Blackie. I think we should move on to our next presentation. This will be assessing hearing loss in clinical trials from Dr. Brewer. Please go ahead.
Thank you.
Thank you. And next slide. I'm unable to advance the slides. Thank you. So today I'm going to spend just a few minutes defining and assessing hearing status. And Dr. Blackie has spoken about hearing loss types and degree of hearing loss, and I'll just give a quick review on that. I'm going to talk about the whole idea of defining ototoxicity, as well as how ototoxicity is evaluated in clinical trials, using scales and other criteria, and a bit about the sensitivity and specificity of these scales. Next slide. And next slide. So when we test hearing, we have a number of tools available, and these are reviewed in nice detail in the Brighton collaborative document manuscript. But the most common method for assessing hearing in any kind of a screening or clinical trial is to use pure tones and determine the faintest level at which a person can hear tones by having them indicate in some way that they've heard the sound. So it's a behavioral test. It requires a response on the part of the patient. The typical pure tone audiometry is done in a sound booth, but screening methods also allow for testing in a quiet room. We have, over the past 10 years, seen the development of tablet-based audiometry that allows for the audiometer to be much more portable, and boothless methods that allow the use of noise-canceling headphones to block out background noise and get close to levels that match a sound isolation booth. Pure tone thresholds can be established on most patients behaviorally aged probably 2 and above. Maybe some really good skilled audiologists can get consistent behavioral responses on younger ones. They're often reinforced by other test methods such as otoacoustic emissions. And otoacoustic emissions are a simple method of looking to see how the inner ear is working. It can be used in newborns. It's what we use for newborn hearing screening, but it can be used in any age. The limitation of otoacoustic emissions is that they differentiate normal hearing or near normal hearing from some degree of hearing loss, and there's no differentiation between the mild hearing loss and the severe or profound hearing loss on otoacoustic emissions. Tympanometry is not a hearing test. It is an objective measure of middle ear function, and it is useful in identifying middle ear fluid and can be used to rule out or to identify a conductive hearing loss when a sensorineural hearing loss is what is being defined as a case or as an ototoxic change. Auditory evoked potentials are used in some cases to determine hearing thresholds, and they give an estimate of what the pure tone audiogram might show. They are equipment and time intensive. They require attaching electrodes to a patient's head and putting sounds in their ears, and measuring a response that is time locked to stimulation of the auditory system. There are telehealth approaches to hearing assessment, and these include some tests, like there's a test called the triple digits test that 3 digits are presented in background noise, and the level of the noise changes, and a threshold for the noise signal or the signal to noise ratio is obtained, and this allows estimation of hearing loss or not. And then there are hearing loss questionnaires, but as we heard from Dr. Blackie, patient self-report of hearing is not always accurate. Even some people, as she said, with a moderate hearing loss might deny that they have hearing loss. So they're helpful, but they're not always reliable. We may miss patients that way. Next slide. So pure tone thresholds in general are our gold standard for clinical trials, and the other measures, otoacoustic emissions and auditory evoked potentials, while they can be proxies for the pure tone threshold, there are no existing standards for when a change is a significant change, and would be cause to say that this is an event related to a treatment, or that that relates to a ototoxicity grading scale. Next slide, please. So when we test hearing with pure tones, we're looking for two things. We're looking for type of hearing loss, and a conductive hearing loss is a hearing loss that occurs because of a dysfunction in the outer or middle ear, and this can range from cerumen blocking the ear canal to perforation in the tympanic membrane, dislocation of the ossicles, or fluid in the middle ear. And we don't typically think of these as an outcome from a treatment, but they can be an outcome. Certainly fluid in the middle ear can be an outcome from a disease. Sensorineural hearing loss is the result of a dysfunction or damage to the inner ear or the cochlear branch of the 8th cranial nerve, and in some cases it's also defined as involving the central auditory pathways. And then a mixed hearing loss is a term that we use for a hearing loss that's part conductive and part sensorineural. Next slide. So on the audiogram, on the pure tone audiogram, what we're doing is we're measuring hearing threshold, and you see that on the y-axis there. And the numbers go from -10 to 120, and that represents the level of the sound. And we're looking for the faintest level at which a person responds 50% of the time. And that's called their threshold. And it's typically measured over the frequency range 250 to 8,000 hertz, which you see on the x-axis, and plotted as an audiogram. Now, this helps to determine the degree of hearing loss. Next slide. And there are various degrees of hearing loss. 15 decibels or better is defined as within normal limits. And then you see that the amount of hearing loss ranges from slight to profound. And there are various definitions of the degree of hearing loss. I've used the ones on this particular plot that correspond with the Brighton paper. And next slide. And here I've plotted an audiogram, and you can see that the thresholds for this person are largely within normal limits. There's one at 20 decibels, but one threshold there at 20, but the rest are all within normal limits. And we would call this normal hearing, certainly normal hearing in an adult. And the red is the right ear and the blue is the left ear there. So 2 normal hearing ears. And next slide. And here we have an audiogram of a patient with a hearing loss that it ranges from mild to profound, but it doesn't involve 250 hertz. Hearing at 250 hertz is normal, and then it slopes off in the high frequencies. And I put this on here just to show you that it's difficult to capture a hearing loss with a single term, because this person has normal hearing to profound hearing loss depending upon which frequency you're looking at. Next slide. So I gave you the flavor of what the pure tone audiogram looks like. Now I want to define ototoxicity. I'm going to begin with the textbook definition. Next slide. And this is a definition that a group in the United States working with the Department of Defense came up with several years ago. And it is damage to the inner ear, targeting the cochlear and vestibular structures and sensory function due to exposures to certain pharmaceuticals, chemicals, and or ionizing radiation. So this is saying ototoxicity is, or a change is a is damage to the ear. So what exactly does that mean? How do we apply that to interpreting whether something causes a change in hearing? Next slide. So I'm going to review both operational and functional approaches together because there is overlap in the two of these. Next slide. So we use an operational definition to basically say, how should the hearing test results be interpreted? You saw that one audiogram that ranged from normal to profound. What's going to make us say that this person is a case? They have sensorineural hearing loss, or that their hearing has changed from a baseline, as well as the other thing that we consider are functional and subjective factors. Does the person's change in hearing impact their daily living? Do they need a hearing aid? Do they need a cochlear implant? Are they able to communicate effectively with others? And does the person have a hearing complaint? And in the case of a clinical trial, we might say, do they have a hearing complaint that didn't pre-exist their treatment? Next slide. So these operational and functional definitions, their purpose is to set criteria and metrics. This allows consistency and objectivity in data interpretation. And it ensures that I'm interpreting it the same way you're interpreting it, and that in turn that we're both reporting it in the same way and communicating it in the same way. And sometimes this has an impact on patient care, and sometimes it has an impact on understanding drug safety. And this is certainly the application in the clinical trial world, and helps us to identify whether an adverse event has occurred. Next slide. Next slide, sorry. So when we use these operational criteria, we're asking questions like, is there a hearing loss, or has there been a hearing change? Or we're assigning grades that say, there's been no change, we're going to give this a grade 0, or there is no hearing loss, versus the hearing loss is impacting the patient to the point that they need a hearing aid, or there's been a certain amount of change in hearing, or a grade 4 in this example is that they might need a cochlear implant. These scales are designed to be applied to adult patients separately, for the most part, from pediatric patients. And I've listed a number of the scales on the side there, and I'm going to go through a few of them. I will tell you up front that there is no one gold standard on these scales. I have chosen to review the ones that are used the most often in clinical trials right now. And I'm going to begin with the next slide. The ASHA ototoxicity criteria. Now, ASHA is the American Speech Language Hearing Association. And in 1994, they published a paper that said, if a person has a change in hearing that's greater than 20 decibels from their baseline test at a single frequency, that can be interpreted as an ototoxic change. If the change is greater than 10 at two adjacent, greater than 10 at two adjacent frequencies, or if they had a response at a frequency that was near the output limits of the audiometer, so say 100 dB, and the next time you test them, they have no response. If that occurs at 3 consecutive test frequencies where responses were previously obtained. So they have 3 separate definitions. But in the end, next slide, the ASHA criteria tell us that there's been a change in hearing. It's a yes/no criteria. It does provide early detection. It's probably the most sensitive of the ototoxicity definitions, because that 10 decibels at 2 adjacent frequencies is close to test-retest reliability. It doesn't assign a grade then, it's just, as I said, yes or no, and the patient serves as their own control. Next slide. The next grading scheme I'm going to talk about is the National Cancer Institute's grading scheme. It's called the CTCAE, which stands for Common Terminology Criteria for Adverse Events. It's a grading, and it includes both changes in hearing and therapeutic needs of the patients. Next slide. The grading scale for the CTCAE goes from grade 1 to 5. So grade 1 is, let me just precede this by saying this grading scale is not limited to hearing. In fact, it applies to many, many systems in the body. And the cancer group came up with this because they're giving therapeutic drugs that have a lot of side effects and potential adverse events. So this CTCA looks at kidneys and eyes and heart and lungs, and hearing is in there. In fact, hearing was one of the original 14 or 15 areas evaluated in the very first iteration of this. The idea is that as each grade goes higher, it's telling you a little more about the severity of the adverse event on the patient. So grade 1 is mild, and it may be asymptomatic or mild symptoms. It may not necessarily be confirmed by, say, an audiogram, where the patient comes in and says, I am not hearing well since I had my Lassa virus vaccine. But you can't confirm that on a hearing test. You can grade that as a 1. The patient has a complaint. Grade 2 is moderate, and non-invasive intervention may be indicated. For the audiology world, that might mean advising a patient in effective listening strategies. Grade 3 is considered severe, and although we don't put people in the hospital for prolonged periods for hearing loss, it's disabling to the person. And grade 4 is life-threatening consequences. You don't think about that with hearing loss, but in the world of the CTCAE, hearing loss could be graded to grade 4 if the person needs to have a cochlear implant. And then grade 5 does not apply to hearing. Next slide. So the definition of hearing loss by the CTCAE for a grade 1 in adults, this is adults only, in a monitoring program. And what they mean by that is a patient who had a baseline audiogram. To get a grade 1, the person needs an average threshold shift of 15 to 25 decibels at 2 continuous test frequencies. Grade 2 is the same amount of shift. Is greater than 25 dB at 2 contiguous test frequencies. Grade 3 then moves on to greater than 25 at 3 frequencies. And the grade 4 says thresholds greater than 80 decibels at 2000 hertz and above. So that's the lower end of the high frequencies, and non-serviceable hearing. Next slide. The CTCAE also considers people that do not have a baseline audiogram, and that's what they mean by a monitoring program. We need to have some way to grade them. And so the CTCAE says if the patient complains of a hearing problem in the absence of documented hearing loss, they're a grade 1. If they have a hearing loss and need a hearing aid, and rather don't need a hearing aid, rather need a hearing aid or don't need a hearing aid. That's a little bit confusing there. They're a grade 2, and a grade 3 is hearing aid indicated. And the grade 4 is not listed in those who don't have monitoring because the non-serviceable hearing captures that. And then CTCAE also has some pediatric definitions. Next slide. And in the pediatric definitions, the grade 1 is based on threshold change, so that requires a baseline audiogram. And grade 2 also requires a baseline audiogram. But grade 3 can be a combination of need for a hearing aid or a certain amount of threshold shift. And then grade 4 is cochlear implant. Next slide. The Boston SIOP, and SIOP is the International Society for Pediatric Oncology. They have a grading scale designed for application to pediatric patients. Next slide. This is based on sensorineural hearing thresholds, and the hearing loss must be a sensorineural hearing, so it must be sensorineural. So it's either bone conduction thresholds or air conduction alone when their tympanogram is normal. And again, this is absolute thresholds for children, not a change. And the rationale behind absolute thresholds for children is that most children have normal hearing to begin with. The same assumption is not made about adults because we all have decline in hearing as we age, and aging of the ear begins in our 20s, in the high frequencies for sure. So the Boston SIOP has graded the hearing loss based on the threshold and the frequency at which it starts. So it gives a grade 1 for a threshold greater than 20 decibels for the high frequencies for 4,000 hertz, or above 4,000 hertz for 4,000 hertz and above, and for 2,000 to 3,000 hertz, and gives a grade 4 when the hearing exceeds 40 dB for 2,000 hertz and above. Now, just to give you a little perspective on that, the speech frequencies are 500 to 4,000, 3,000, 4,000 hertz in general. The high frequencies contribute substantially to our ability to discriminate speech. Next slide. So the SIOP doesn't require a baseline audiogram, but it's intended for pediatric use only. Next slide. And then I put the Brighton collaborative case definition here, and I know that the next speaker is going to talk about the case definition. So I'm just going to go over this very quickly in one slide, what they will, the next person will take a few minutes to do. So next slide. The case definition for Brighton says a hearing loss of at least 30 decibels in 3 sequential frequencies. That this hearing loss should be sensorineural, that conductive hearing loss should be ruled out. And these criteria pretty much match the American Academy of Otolaryngology head and neck surgery's criteria for defining sudden sensorineural hearing loss. The Brighton group also recommends hearing at baseline when there's concern for sensorineural hearing loss as a post-immunization event. So the original part of the definition just says thresholds of 30 dB or more, but the group also recognized that if there's concern for sensorineural hearing loss as something that occurs after an immunization, there should be a comparison to a baseline. Next slide. So this is also a yes/no definition. And as far as my read of the Brighton document, it does not provide guidelines for interpreting change in hearing. It talks about thresholds, but it doesn't say how much change is a significant change. Next slide. So how do these scales compare? And this is somewhat sensitivity and specificity. So let's just take a look at I have 2 cases here. Next slide. Here is an audiogram of a patient who has hearing thresholds that are normal in the low frequencies, and then a hearing loss that ranges from mild to severe. After vaccination, the patient was fit with a hearing aid. So is this an adverse event? Let's click through the next few slides that are going to build on this. According to ASHA, next slide, it can't be determined because there was no baseline exam. The CTCAE would grade this as a grade 3 because the person needs a hearing aid. Boston PSYOP would grade it as a grade 4 because thresholds, one more. Oh, no, okay, I see what you did. Back up one. Let's see. Thresholds for the Boston PSYOP would be graded as a grade 4 because there are thresholds greater than 40 at 2000 hertz and above. And Brighton would classify this as a sensorineural hearing loss because thresholds exceed 30 dB at 3 contiguous frequencies. Next slide. Now it's the same hearing test, only now we have a baseline examination on the patient. So let's see how that changes our interpretation of this particular audiogram. Next slide. So ASHA would say there was no change in this person's hearing, so no evidence of ototoxicity. The CTCAE would grade it as a 0. There's not enough change in hearing, and the person needed the hearing aid prior to the vaccine. Boston PSYOP would still grade this as a grade 4, and the Brighton case definition is met here, but based on the thresholds of greater than 30 dB at 3 frequencies. So ASHA says no, Brighton says yes, CTCAE says grade 0, Boston PSYOP says grade 4. That's a little bit confusing. Next slide. Here's another audiogram. Hearing is close to normal. This person, we cannot determine if they've had an ototoxic change in their hearing because we don't have a baseline audiogram. The CTCAE would give this a grade 1 because the patient is complaining of a change in their hearing and they don't need a hearing aid. And continue. Next slide. Boston PSYOP would grade this as a grade 3 because thresholds are greater than 20 dB for 2000 hertz and above. And Brighton, next slide, would call this no sensorineural hearing loss because hearing thresholds don't exceed 30 dB at 3 consecutive frequencies. Okay, let's look at this person's baseline audiogram. Next slide. And now we have data that allow us to say this person had really good hearing at the beginning. So by ASHA, they had a change in their hearing. The CTCAE grade would be a 3 because there's been more than a 25 dB change at 3 frequencies. Boston PSYOP is still going to call it a grade 3 because it's only looking at the post test. And Brighton would continue to say no sensorineural hearing loss based on thresholds not exceeding 30 dB at 3 frequencies. So having the baseline exam changed, ASHA and CTCAE and Boston and Brighton held steady. Okay, next slide.
We could wrap up.
Sure, next slide.
Thank you.
Yeah, so I just quickly want to, you all know about clinical trial phases. I don't know if there were any preclinical studies done on any of the vaccines under consideration for Lassa virus to determine whether there was an associated hearing loss associated with the vaccine. In phase 1, where we're looking at primarily human safety, and phase 2, we're expanding safety, we probably, at least in the phase 2A and baseline, obligated to do some kind of a baseline test. Whether baseline tests need to be done in phase 3 and 4 may depend on the findings in phase 2A. What if there are no hearing losses in phase 2A? Okay, next slide. This is a complex topic. There are a lot of factors to consider. Among them are feasibility, resources, time, and cost. How sensitive is the measure? And on the other hand, how specific is it? We don't want to be calling hearing loss when it isn't a hearing loss or it isn't related to the vaccine. There's no single best metric, and the protocol that is used may vary over the clinical trial phases. And that should be the last slide. Yes. And I guess you're telling me I don't have time for questions.
No, I don't see questions right now in the Q&A or in the chat. I will give people just a few seconds to change their minds, but that was very helpful. Thank you for reviewing that. And yeah, it is a little humbling to see that it's not all cut and dried, obviously, from the audiology perspective.
Yeah.
It's important information for us to be aware of.
And someone asked, please specify that these case examples are hypothetical. Yes, they are hypothetical.
All right, I don't see anything else in the chat, so I think we'll take advantage and move on to a very brief presentation on the Brighton case definition for sensorineural hearing loss from Flor Munoz. Flor, take it away.
Thank you so much, Corey, and thank you, everyone. So as Corey mentioned, I have worked on the Brighton case definitions, and in this particular case, if you move on to the next slide, as a response to a meeting in 2019 regarding Lassa and how to assess safety, a group was put together where we have experts in ENT and audiology, experts in vaccine safety, experts in Lassa fever, and others who have been participating in a number of Brighton collaborations in the past. We have a large representation from different geographies as well. So the Brighton collaboration case definition was published in 2020, and it has actually been used in the evaluation of adverse events following COVID-19 infection and also vaccination. And I would just like to mention that, the Brighton case definition's purpose is really to try to identify a standardized or more unified way of assessing a particular adverse event and looking at it in the context of immunization, providing some guide for ascertainment of a case based on different levels of certainty. So the next slide, please, is just going to show you how, in the process of developing this case definition, I know the text is very, very small, but the point is that we always find numerous case definitions or definitions of an event in the literature. And in this particular, for this particular term, it was very clear that we were focusing on sensorineural hearing loss. And even for that, as you can see, there were different definitions in the literature, going from very specific definitions, including, of course, the testing, to basically deafness, which is a general condition of impaired hearing. So we list those in the document, and we list also all of the sources of the definitions that are out there. But you can see that in general, for sensorineural hearing loss, which is to be differentiated from conductive hearing loss, I think that overall in the literature review, the definition of a loss of 30 decibels or more at one or several frequencies was pretty consistent. And this is the table that was shown by the previous speaker as well, where you see that when you look at just a threshold to identify hearing loss, any level above 30 would be potentially considered consistent with sensorineural hearing loss according to a number of definitions. The next slide is just to show you again that the case definition was following the American Academy of Otolaryngology, Head and Neck Surgery, as was mentioned before, and the National Institute of Deafness and Other Communication Disorders, as well as ASHA, as was mentioned before. And the working group really try to define a threshold, as was already stated, as a guide to be able to have consistency. And this was the most consistent definition across all the literature. So having a loss of at least 30 decibels and 3 sequential frequencies in a standard pure tone audiogram. So we've already heard about the potential different causes, and certainly a vaccination or an infectious problem could be one of the causes. But it is a very particular type of hearing loss where you have already injury to the inner ear, the nerve, or the processing center in the brain. So I think that one of the main keys here was that one needed to, for a higher level of certainty, distinguish from a conductive hearing loss. And for that, you need at least a physical examination and audiometric evaluation that would be consistent. If you go to the next slide, this is really, I think, important to keep in mind, because what has been shown in some of the examples before in terms of the hearing loss of greater than 30 decibels in 3 sequential frequencies of an audiogram is really pertaining to level 1, which we would consider potentially a definite case. You see that that is the greatest level of certainty when you have that option, but that if someone does not have an audiogram but has a different type of test, of course, the main point here, as you see in all levels, is to already exclude conductive hearing loss, which is done with a physical exam. But someone can have an ABR, or they can have even a tuning fork exam and still be able to have that level 2 of probability. And level 3 could even be really just consistent with either some more indirect testing, or the person expressing concerns for hearing loss. And so I would just say that there are ways of still being able to identify and classify a case, even if you don't have the audiogram, or the audiogram is not consistent necessarily. The next slide. It's a little bit slow on my end. Thank you. It's just to tell you again that it does provide additional guidance, as was mentioned by the previous speaker. This document is meant to really just give the basic guidance in the context of looking at post-immunization events. And so ideally, you want to have a baseline, but there are also additional guidance regarding how to report the event. If you have sudden hearing loss, you need to look at the intervals between immunization and the event. And this is just a suggested way of looking at when they occur to look for potential association, although the Brighton definition does not assess causality or severity per se. And this was provided as a guide. You know, you could report in things that happen within a week, within 4 weeks, or 4 weeks after. As a reference, I can tell you that there have been a number of case reports associated with vaccination, including influenza vaccine, mumps, measles, hepatitis, even tetanus, diphtheria, and meningococcal and rabies vaccines. But there has only been one study that looked at exposures of 28 different vaccines within 14 days or within 28 days prior to an event of hearing loss. And that's 4 weeks after vaccination. And there were no associations identified in this study. This was done by the Kaiser Permanente group in the US. There have not been any studies, at least to the time when we developed this definition, of hearing loss occurring late after a vaccination, so more than 4 weeks. So this would be a different thing. And then I just want to point out again that the guidance is suggesting reassessments. So I know that that has been a question, you know, difference between baseline and changes or over time. There is implication that one needs to consider reassessment, because you look at duration, more than one measurement, distribution of the cases, and here's where we have the suggestion of having a control group or comparison group or background rates to be able to really ascertain whether there's any association with a vaccination. And the last slide, just wanted to make the point again that this document is a supplement to the main paper that provides all of the rationale as to the Brighton case definition. And again, it does include some descriptions of how to use it in the context of a clinical study or an observational study or even passive surveillance, so that all of these things that are listed here, the study design, how you're measuring it, what type of surveillance, what kind of testing is being done, and what the comparisons group, what instruments are utilized, all of these things would need to be considered in a study. But the case definition is not really meant to give at extensive detail how to design the study. It's really, again, just a guidance. And I have to say, it's very interesting to see very specific examples of how things would fall depending on different definitions, and how these different definitions could be applied in a clinical study. So we are very much open to continue to improve these definitions as they're utilized, and validation studies are being conducted out there. So I will stop there, and thank you for your time this morning.
Thank you so much, Flora, for that presentation. I don't see questions in the Q&A. It was very clear what you presented, so I will take advantage and move on to our next speaker. We now are moving into getting perspectives from two of the developers that have been testing candidate vaccines. The first speaker will be Dr. Gideon Akintunde from Emergent, and he will give us his perspectives based on experience from Emergent. Thank you. Go ahead, please. Gideon, are you muted by chance?
He's not muted. He has his microphone on. But Gideon, we can't hear you if you're talking.
All right. Perhaps then what we can do is switch order. Pat, are you available to talk about IAVI's experience in clinical trials?
Yes, I am.
Great.
So
Yeah,
I may
second,
need to turn off my
will-
video while I'm during this talk, because even though
I
I
will
live in
advance
Silicon
the
Valley, my internet's not always stable. Okay. So hi, I'm Pat Fast, Senior Technical Advisor for IAVI, and speaking on behalf of our team. We really have been looking forward to this seminar and hearing from some experts, because it is a rather difficult field for non-audiologists to get their mind around. And thanks, Dr. Brewer, for confirming that it's not all that simple. We appreciate that. Okay, so if we can get the next slide, please. All right, this is just to say thanks to our donors, and in particular for this program, SEPI and EDCTP are our funders. And SEPI has been an enormous supporter of this work. Next slide. Okay, so just very quickly, what is our vaccine? This vaccine is a replication competent, so it has limited replication, VSV chimera. So VSV is an animal virus that very seldom causes any problems for people. It's attenuated by the modifications that are made. And the Lassa virus glycoprotein is added, is used to replace the normal, I don't know if you can see normally it attaches, VSV attaches via G protein. However, that protein is removed genetically, and it's replaced by the Lassa virus protein. So this has the same propensities for what cells it infects and so on as Lassa virus, but is very limited replication competence. It has been studied in animals, and it protects them completely against viremia and against infection and disease from Lassa virus. It works very quickly, and it works for at least a year. Hasn't been tested longer than that. In our hands, our particular vaccine induces antibodies that neutralize the Nigerian strains as well as other strains of Lassa virus, but and in animal models, other cross protection has been shown between lineage 4 and other challenge virus, but we haven't shown that specifically. There are T-cell responses fairly low in the monkeys, quite a lot of antibodies, including neutralizing antibodies, and the protection is just very consistent. So that gives you the background on why we're enthusiastic about the vaccine. Next slide. Now, as was pointed out by previous speaker, we have not actually tested hearing in the macaques that were vaccinated and protected, but they're they're completely protected against any visible manifestations or measurable manifestations of Lassa. So this is our phase 1 trial, which is coming to a close. We're just in the last few months of follow-up for the second portion of it. So first portion of it was in the United States, and the second portion of it was carried out in Liberia by the Prevail and with the help of their NIH collaborators, and that they have a lot of experience with Ebola vaccine of this type as well. The second study and I just to say very briefly that there were no safety problems, including hearing loss, and there was good immunogenicity in that study. So the phase 2A is beginning very soon as we get the final clearances from everybody. And in that, we'll have healthy adults, we'll have adolescents, we'll have children, school-age children, we'll have toddlers. So it'll be 18 months and above. And this is a dose escalation and age de-escalation design. So it's being done very carefully. And we'll have people living with HIV. Now, all of these groups have been vaccinated with a very similar Ebola vaccine called Ervebo that's owned by Merck, and all of them do well in that situation. And so we're hoping that this will start enrolling soon with healthy adults and adolescents and people living with HIV. And then we're planning efficacy trials. And right now our plan is to do a phase 2B trial. So this is a test of concept trial. And we hope that this will provide a lot of information about hearing, as well as many other things, particularly in the comparator group. And eventually a pivotal phase 3 trial when we have our final material and so on. So let's just move on to our thoughts about hearing, unless we can come back to questions. Next slide, please. Okay, so first problem that we have is, the hearing loss prevalence and incidence of hearing loss are not very well documented in West Africa. I found one big survey paper in which they said, well, there were some pockets of in West Africa of very high prevalence, but they had sort of dismissed that because they thought maybe that was not correct. But I think many of us, including Dr. Blackie, for example, think that may be correct, in fact, and it may be related to loss of fever. So we know that Lassa fever causes sensorineural hearing loss. This has been reviewed in at least a third of cases, and some recent studies have suggested much higher, although it might be strain specific, because sometimes there are different outbreaks that seem to have somewhat different manifestations. And people have suspected, as I said, that mild or asymptomatic Lassa virus infection, which is very common, about 4 times as frequent as diagnosed Lassa fever, at least, could cause sensory hearing loss as well. But as others have alluded to, there are many other causes of that toxicity, as various substances is one, and other infections, including CMV and mumps and just numerous other infections, even ones that might be fairly mild, can cause it. And so the causes are often not identified. Even in a place like the United States or Europe, they're often not identified. So in some West African regions that we are planning to work, there are very, very limited audiology services. I was told a couple of times by people in Liberia that basically one cannot really get hearing aids in Liberia. So we're working on a background that requires the trial organizers to come up with a good system and to somehow find a way to do effective referrals, first of all, for more thorough diagnosis. And hopefully we can find a way also to assist people, at least people in the trial, who have hearing loss, whether or not it's associated with the vaccine. That's a little more difficult, but I'm trying to think of a way to bring in somebody whose primary focus is on hearing. Maybe that we could do that, because it's very troublesome to cannot or will not be treated. In Nigeria, which is where fever is, there's of course a lot more capability. So that's great. Next slide. Could we have the next slide, please? Thanks. Okay, so we're thinking it's a potential adverse event, and that is really the focus of this meeting. But it also could be a potential efficacy endpoint for the vaccine, because anything that's a sequela of infection could potentially be prevented, or I suppose hypothetically exacerbated by vaccination. I do want to point out that even if this is an immune-mediated problem, that's what people think, but the immune mediation may be focused on cells that are in fact infected with Lassa virus, which that doesn't exist in our vaccine or in any vaccine. And also the vaccines that exist right now are all based on just one of the antigens. So there's a lot of antigens in a Lassa fever virus that aren't even represented in the vaccine. But if we think that there's our hypothesis could be that based on this presumed immune mechanism, one could cause harm by vaccination. A very, logical hypothesis. What we found so far is in our phase 1 trial, there was no hearing loss, which we did by pure tone audiometry in Monrovia, and that was, required building a soundproof room, and it was kind of an elaborate process, but I think we got good data from there. And there's been no report that I'm aware of from a couple of other trials of Lassa glycoprotein given in different ways that there was any hearing loss. So as far as we know, there's no evidence for this hypothesis. Now, the other one is the hypothesis is that a preventive vaccine could prevent any manifestation of Lassa fever, including hearing loss. And there's also no evidence for that right now, because we haven't had an efficacy trial. All we know is that a lot of patients with the diagnosis of Lassa fever and to some extent have developed sensorineural hearing loss, although there's usually not a baseline. And we think that it's potentially possible that a mild or asymptomatic infection could cause sensorineural hearing loss. Next slide. So how are we going to approach these things? And this is where we're hoping to get some advice or help First of all, we would have a baseline assessment in all the participants. It's very difficult, and I think Dr. Brewer gave some great examples to make any assessment in a place where there's not, especially where there's not good hearing care and not access to hearing assessments. Make an assessment if you don't have a baseline. So what we would plan to do is a pure tone audiometry screen, hopefully not as extensive as some of the data that's been shown here for the screening, for 7 years and older, or at least for children that can understand. And then otoacoustic emission screen for 6 years and younger. This was the FDA did point out to us, they didn't think that parent report was adequate, and I agree with them. So then we would repeat the screen. If it's still positive and there's no clear cause like cerumen blockage, then we would have to refer for a full audiology workup. And this would be everybody in phase 1 and 2A. We're actually testing. That's, we're testing with a pure tone audiometry. We did test in phase 1 and we will test in phase 2A or with OAE, depending on their age. And then in phase 2B, we're thinking that we'll get a baseline, and then if hearing loss is reported, we would assess and possibly assess in a subset. We think our current plan is about 11 to 12,000 people would be in the phase 2B. That's a lot of audiology exams. So it's a little bit daunting to think of doing repeated examinations in 12,000 people. But this is, this is why we're here discussing our potential approach to see what people think. As an efficacy endpoint, we would have a baseline assessment for all the participants, of course, and then we would do the screening. And then after Lassa season, we would be testing probably, well, 2 different, for anybody who got Lassa fever would be tested, of course, as they typically are now. And also people who seroconvert to the internal antigen Lassa nucleoprotein, because those people have evidence of infection, and then appropriate control. So we could do some kind of a nested study to see whether even people who don't get sick, but who do seem to have gotten a Lassa infection, do they in fact have deafness after their Lassa infection? And is it in fact prevented by the vaccine? Can we have the next slide? Okay, so basically this is just another summary. So we would get probably pure tone audiometry in older children and adults at 2 frequencies and 2 decibel levels, just to get kind of a quick look. Check for obvious causes, refer if there's no clear cause, and refer to an audiology team that would be able to do a more appropriate full analysis, or maybe not what some of you in the audience would consider a full analysis, but a more thorough analysis. And we can certainly use some help with advising us on techniques and so on. It would be very helpful if people have thoughts. In phase 1 and 2, we did screen out people with hearing loss. We found a lot of it, particularly in certain parts of Monrovia. Most of it is pretty much high frequency and not the rest of the spectrum. Most of it's partial, and most of those people still function well, but we did screen them out because we didn't want complexity. On the other hand, when you get to efficacy trials, you cannot be saying that you have a vaccine that's only good for people who hear well. So we would include all comers, but we would document their hearing at baseline as thoroughly as we can, and then monitor for change in their hearing. So the follow-up would be repeat the screening if the hearing loss is reported, refer for audiology, and of course do an audiology workup after Lassa fever. Next slide, I think. Yeah,
And
so
are we just about ready to wrap up?
Yes, I'm just
Yeah,
saying basically that we need a standard definition. So there we go. Next slide. Thank you.
Perfect. We do have several questions. I think many of them have been answered, I think, as you got further into your talk, but Dr. Okobenin, you had a question. Would you like to unmute yourself, or do you think you've gotten your answer? He was asking which hearing tests were done, and did you do them pre and post vaccination in your clinical trials?
Yes, we did.
Different frequencies.
Pre and post
To that.
ear tone audiometry.
Yeah. Other
Hi, Prof.
questions? Dr. Brewer has a comment that you could probably do pure tone screen on younger children. Dr. Brewer, do you want to amplify on that at all? You can unmute yourself.
Yeah, sure. We audiologists are able to get pure tone thresholds on children as young as 2. We use a technique called play audiometry, which engages the child. Of course, a 2-year-old, you never know what kind of mood they're going to be in and how cooperative they'll be. But I think you could pretty much count on pure tone audiometry 4 and above. And 2 to 3 is very likely. Of course, that's with a skilled audiologist doing it. And if it's a technician, it may be a little more difficult, but it can be made into a game. There are iPad versions of games.
It will be a technician, and it will be a strange person coming into in a relatively rushed situation. So I understand that can be done in ideal circumstances. I don't think we'll be able to provide the ideal circumstances.
Yeah, I think you could go down to H5 though easily.
Okay, thank you.
In circumstances, yeah. But I did have a question. So how did you define hearing loss in your group? You said there was no hearing loss. How was it defined?
30 in the phase 1, it was just 30 decibels. We didn't specify a number of it contiguous.
So any one frequency at 30 decibels.
Yes.
Thank you.
And we did see a little bit of wiggle and coming, up and down a bit, as you pointed out. But we did not see anybody reach that threshold.
Great, thank you, Pat. Nicholas Reed had a question. Some of the tablet audiometer companies have gamified pure tone audiometry. So that may be another option to consider. Nick, would you like to amplify on that? You can unmute yourself.
I mean, yeah, it's pretty straightforward. I was just sort of amplifying what Dr. Brewer was saying, that it is sort of gamified, and it is something that's efficacious with technicians, and you can do it. So I wouldn't worry as much about that. And there's now some lit, even in some examples where they've used their gamified system with kids down to 3 years old. It's essentially just like a drag and drop little game on the screen when they hear tones, and it's very similar to play audiometry in the booth. And it's, it is feasible.
Yeah, I'm not sure that a lot of these children will ever, if they've seen a tablet before. I mean, I really don't know that for sure. Sometimes there's a remarkable level of technical ability in rural Africa, but not always. We were using
for context. This is so you use Shoebox?
Yeah.
Oh, that's great. So yeah, for context, we've used Shoebox and HearX in South Sudan work, and I think you'd be surprised how rapidly people can take to pretty straightforward play tasks.
Yeah, I'd like to talk to you about it more and get a time estimate per participant.
Well, thank you, Pat, for enlightening us in terms of the journey you've been on with that vaccine candidate. I know that Gideon was having trouble having us hear him. He is here. Can we try again and move to the next presentation then from Emergent? Gideon, are you with us?
Thank you, Corey. Can you hear me?
Yes, thank you. I'm glad to say yes. Go ahead, please.
Yeah, apologies.
Let me go back to the presentation.
Okay.
Thank you, Pia.
Okay, next slide. So my name is Gideon Akitunde, and I'm the clinical lead for the Lassa program at Emergent. And I want to present our experience based on implementing the Brighton collaboration criteria in our phase 1 trial as part of following up of subjects. So I'll take us through the protocol requirements, how we performed the audiometry, tell us about our experience, and then provide our recommendations for future trials. Next slide, please. Next, thank you. So our phase 1 study is a randomized, blinded, placebo-controlled dose escalation and dosing regimen selection study, which was conducted, which is being conducted in Ghana at 2 sites in Ghana at Navrongo and Kitampo. You can look up more details on the trial on PACTA. That's a Pan-Africa Clinical Trials registration number there. So as part of the protocol, we included a hearing threshold between -10 to 15 decibels, essentially normal hearing across low, middle, and high frequencies, just because we wanted the phase 1 to be as controlled as possible, and we won't have to worry about adjudicating cases of sensorineural hearing loss if they occurred. So we essentially ensured that we included only subjects with normal hearing across the sequential frequencies, low, middle, and high frequencies. And we excluded subjects who had any history of hearing loss of any other condition which may be associated with sensorineural hearing loss. So essentially, we ensured that all subjects, or the protocol required that all subjects enrolled into the study had normal hearing. As part of follow-up procedures post-vaccination, we also solicited sudden onset sensorineural hearing loss in all subjects as defined by the Brighton collaboration. And that means there has to be at least 30 decibels loss of hearing across 3 contiguous frequencies in a standard pure tone audiogram, and that's after excluding conductive deafness. The protocol also required that any abnormal audiogram findings or any hearing loss be classified by severity, and it's the same severity, that is the same classification provided in the Brighton collaboration paper that we included as part of the protocol. We also had an independent safety monitoring committee provide oversight over the study. And interestingly, Dr. Brewer was the audiologist on our SMC. So it's good to hear her present perspectives and potential recommendations for future studies here. And also, as part of the safety monitoring committee, we had a member of SPEAC. SPEAC has a Meta DSMB, and we had a member who sat there, an observing member who reported back to SPEAC outcomes of our safety review meetings. Next slide, please. So in order to assess if hearing loss had occurred in our subjects, the protocol required that a questionnaire be administered prior to audiometry at every visit, and it will ask questions on any changes in hearing or any ringing in the ears. Then the investigators are required to conduct a physical examination to exclude conductive hearing loss. Audiometry was performed using shoebox audiometry, which includes a calibrated pair of headphones, an iPad, as well as an online portal where we, as well as the sites, could see the data being provided. And of course, the protocol required audiologists at clinical sites to conduct and review those audiograms. We assessed hearing at screening. Like I said, we had inclusion-exclusion criteria, which we had to address to enroll subjects. So we assessed hearing at screening, then at baseline prior to vaccination. And we also did that at 1 and 2 weeks post-vaccination. Our vaccine required 2 doses administered 4 weeks apart. So we we conducted a audiometry assessment before each vaccination visit, 1 and 2 weeks after each vaccination, and 1, 2, and 4 months after the last dose of the vaccine had been given. Next slide, please. So in terms of our experience, I think I'll start off by saying, by reacting to a question Dr. Brewer may have brought up earlier about whether there are non-clinical data supporting indicating any potential for sensorineural hearing loss. So we have conducted repeat dose toxicity studies as well as neurotoxicity studies in non-clinical studies, which have not shown any indication of neurovirulence for a vaccine and have not shown any indication for hearing loss. So from a preclinical perspective, there's really no need to, there's no potential right now for the vaccine to cause sensorineural hearing loss. So in terms of our experience, based on the inclusion criteria, which required for subjects to have a PTA average, which is normal, as well as normal in all, in the low, middle, and high frequencies, there were differences in its interpretation of that criteria by the two sites. So one site was able to enroll subjects who had normal hearing at baseline, which was also normal within the middle, low, and high frequencies. The thresholds, the PTA thresholds were within normal limits. But the one other site, when the enrolled subjects who had normal hearing, that's PTA between -10 and 15, they did not consider the individual frequencies. So there were some confusions around that inclusion criteria. The other thing that came up earlier on in the study was that hearing loss could have been misinterpreted as either a change from baseline or an absolute value. So if you look at the audiogram picture that Dr. Brewer presented earlier on, the greater than 30 decibels loss in hearing could be interpreted as a change in hearing from baseline of more than 30 decibels or an absolute threshold that is greater than 30 decibels across those different frequencies. That was also that caused some sort of confusion. In terms of how abnormal audiogram findings were reported, we found out that in some cases, investigators were reporting abnormal audiogram findings in single frequencies as AEs. And the rationale is that we had provided the inclusion criteria, we have the Brighton collaboration criteria, and then we had the toxicity grading, which they were required to complete if there was any change in hearing. So they had to document that as they had to document those changes, even though there were no signs, there were no clinical signs or symptoms. And I think the last speaker spoke about this. Most of the changes we saw in the audiogram when most of the abnormal changes were around the middle and high frequencies areas. The other thing that came up was that the grading scale and case definition for sensorineural hearing loss did not account for asymptomatic changes in hearing. So, from the investigator's perspective and from our perspective, if a subject came in and you administered a questionnaire, was there any ringing in the ears? Was there any change in hearing? And then those responses were no. By the time you do the audiogram, because of inconsistencies and changes in the audiogram, probably due to fatigue on the part of the subject, we noticed changes which were inconsistent over time and were not meaningful in terms of trying to interpret these changes. And like I said earlier, for most of the changes, if not all the changes that were observed in audiogram, these were all asymptomatic. Then the grading of hearing loss per protocol is not specific. The feedback we have gotten is that the grading does not indicate whether you're observing changes in one frequency or whether you're reporting the hearing loss based on the average PTA value. So these were some of the issues we had. And we had to get Dr. Brewer, who is the audiology specialist on our SFC, involved in helping us to understand the kind of data we were receiving from sites and also communicating to the sites exactly how we wanted this handled per protocol. Next slide, please. For recommendations for future studies, I think a lot of people have alluded to this earlier. More studies are needed to really understand the etiology and clinical cause of sensorineural hearing loss, and also to be able to determine exactly the rationale behind soliciting this in clinical trials. Of course, the exact pathogenesis is unknown. It could be due to it could be immune mediated or due to the viral toxicity. But of course, this has to be better understood in terms of how do you solicit sensorineural hearing loss in a trial where the vaccine itself is not likely to cause that. I mean, in the early stages, you could do studies to look at potentials for vaccines to cause ototoxicity. But at the field efficacy time point, I think it will be difficult to include audiometry at screening because this will not be feasible in real-world application, especially in terms of cost, and also monitoring that data and making meaningful sense out of it. We recommend that audiometry should be performed at baseline in early clinical studies, phase 1, phase 2, and that should be the basis for evaluation of any hearing loss which occurs during the conduct of the study. And of course, there could be an adjudication committee to adjudicate those cases. Then we also recommending here, and I think this may have been addressed earlier in Dr. Brewer's talk, where the kind of scale we're using to grade hearing loss in the study can be tailored to suit the purpose of the study. So for example, instead of using a toxicity grading scale, which says, oh, is there hearing loss of 15 decibels or 25 or 30 in adults, as part of the protocol, we could use the CTCAE grading scale, which determines the impact of the hearing loss on the subject. And that puts things in perspective. If a vaccine is causing AEs that result in impacts on the subject that impacts their lives, then that vaccine is not likely to, so you will have to weigh the benefit versus the risk of administering that vaccine. We also recommend that ear examination and follow-up audiometry should be performed for all subjects if there are hearing-related symptoms. This is something that should be included in future trials as well. And of course, sensorineural hearing loss should be collected as an adverse event of special interest, as it should be. So I believe this is my last slide, Corey. Yes. Are there any questions?
Thank you very much for that, Gideon. And once again, I'm glad we were able to make contact with that. I do not see questions in the chat. I think, again, you were very clear. So recognizing that we got a little bit of a late start, I would suggest that we move on. Our last speaker before the break is Professor Pessler from Galveston, and he will talk to us in a slight shift about mouse models of Lassa and sensorineural hearing loss. Please go ahead.
Well, thank you all, and thank you for the invitation. I'm really glad to see people are starting to look at hearing loss, because it's my passion for the last probably 7 to 10 years, scientifically, but also on the ground in Nigeria. Please, next slide. So Lassa fever, as you know, belongs to the family of arenaviruses. And I just hope I didn't send the wrong file here. Can you give me the next slide? Can you enable me to share my slides? I really apologize. This is a wrong file. I'm going to share my screen right now.
You should be able to share your screen.
Okay. Is it
Yes,
working?
we can see. Yes.
Perfect. Well, we'll start again. So let me just try to walk you through some of the historical data for a few seconds that was mentioned previously by some of the speakers. But basically, from the 80s and some of that from 90s, we do have some data that indicates in the literature today around 30% of survivors developing Lassa fever, very little to no information at all about any mechanistic. And 80% of sudden hearing loss patients are seropositive for Lassa in those old studies. Also, Nigeria has the seropositivity in population, when you look at, is close to 20%. Okay. I work in Nigeria now for a little bit over 7 years at the Jos University and Jos Teaching Hospital. And I'm going to give you some numbers and information from the ground, which might be useful for those that are designing clinical trials. So this is a human study, just one slide, and then we'll switch to the mouse. But basically what I want to have you take home as a message here is that the percentage of hearing loss in hospitalized patients, at least in this area and plateau state, seems to be way higher than literature would indicate it. So we have around 71% moderate or worse hearing loss with the history of Lassa. But even more important is when you look at the seropositivity of patients. So when you look at the hearing aid users at Jos Hospital, you can see that in that population, you have 51% antibody presence in patients. This is an anti-NP, just like Pat was mentioning before. And then the cochlear implant user, yes, the number of the group is small, but basically the percentage is really going up. This is a continuing recruitment. So I think what I'm trying to indicate here is that if you are a hearing aid user, you very likely have close to 50% chance of having had Lassa. And if you have even more severe damage to hearing, like a need for cochlear implant, it looks like, at least in that area, that you have likely Lassa antibodies. So now to the mouse model that we have developed several years ago. We use a STAT1 knockout mouse, which basically we need this knockout in order to initiate Lassa virus replication. Otherwise, fully immunocompetent mouse does not clears Lassa very rapidly. The mouse model reproduces many symptoms seen in humans. And we have developed a model in which, depending on the virus dose, we can go from 50 to 100% of hearing loss development. And that's important for us because the work is done in a high containment facilities, and we cannot work with tremendously high numbers of animals, as you can imagine. In comparison to humans, I think the key message here is that in humans, we have this sudden onset. We have heard today from a physician from Nigeria that it's also sometimes unilateral, sometimes bilateral. What we see mostly is bilateral. It's mostly progressive. It's mostly then not really something that improves over time. And I would guess, based on some of the data, that if it does improve, probably wasn't Lassa. In mice, we can, in contrast to humans, where it's very difficult to come to get hands on the tissue from inner ear. In mice, we can show very impressive spiral ganglion damage, and I'm going to show you that in the next couple of slides. In order to do that, I want to just walk you through this slide so you know what we are looking at. In these slides that I'm going to be showing from mice, we are really focusing on the cochlea and focusing on the auditory nerve. So this is a histopathology. So basically, inner ear cut and put on the slide from mice infected. On the left side, you have STAT1 knockout mice. On the right side, interferon alpha, beta, gamma receptor knockout mice. The reason we use those is that's a control for us for a mouse that's fully susceptible to be infected but cannot actually activate T cell response. So on the left side, what you see here is SGNC. So basically you see a spiral ganglion cells or neurons in your auditory, in a mouse auditory ganglion, and higher magnification on the bottom. So basically the nerve is totally depleted of neuronal cells, where on the other side, on the right, you see a fully preserved nerve. I also want to call your attention to the F on these slides. This is a facial nerve, and facial nerve stays throughout the infection, totally preserved, which correlates with field studies in humans that do not indicate any damage to that head nerve. When we look at the cochlear hair cells in these mice, and these slides are done by my collaborator, Dr. Tomoko Makishima, who is an ENT specialist and NIH-trained physician here at UTMB. We can see maybe a very, very minor damage to hair cells, but nothing that would explain functional measurements that I'm going to show you in next slides. We can find virus antigen in those inner ears, regardless of hearing loss, presence, or absence. Few cells are infected, and you can find them also in neuronal tissue, but nothing massive. What is massive is the infiltration of CD3 T cells into the auditory nerve in the inner ear. And the reason that we have only CD3 and not CD4, CD8 stains is because this tissue has to be legally fixed in formalin for 1 week before we can take it out of the lab. So nevertheless, you can see that tremendous infiltration of T cells present at the end of the study. And now I'm going to take you to the functional measurements in mice that we do. And it's beautiful that Dr. Brewer was able to talk about these, so I don't have to walk you through what they measure. So we do ABR and we do DPO-E. I think we are the only lab that has established that in the high containment for any type of mouse models. So ABR, as you have heard, you have to be able actually to use the probe and put it in the ear to measure the brain response. And this is how DPO-E is done in mice. And now we go to the study, which basically is a loss of function study. So we go into fully susceptible model that develops hearing loss and survives infection. And we deplete the T cells, either CD4, CD8 T cells together or separately CD4 and CD8 T cells. And then we perform these 2 hearing tests over time. At the end of the study, we collect the inner ear and look at those tissues, as I have mentioned that before. On the left, you see survival, and you can actually see that if we deplete CD4 T cells, we do get some reduction in survival, where CD8 T cells likely contribute to initial pathology and damage in the acute phase. So if we deplete CD8 T cells, everybody survives. However, when we look in those survivors now for in the functional tests for hearing, we can see that CD4 T cell depletion fully prevents the hearing loss in this model. We don't know at this stage if it's cytotoxic CD4 T cell response or CD4 T cell helper function, which would indicate B cells and antibodies in this case, but those experiments are on the way. When we look in these mice with hearing loss versus no hearing loss, this is the Rosenthal's canal. This is basically your spiral ganglion cells or your nerve cells. You can see that in the case of here uninfected or completely hearing competent mouse, the neurons are preserved and well stained, where in this infected model and loss of neurons, you can actually see that the neurons are pretty much completely gone. So you can imagine if you are lacking auditory nerve, there is no capability to actually conduct that signal to the central areas in your brain. And we can also quantify that by measuring spiral ganglion density in this model. And if we look at the uninfected and infected, we see significant differences in the density, which means basically less cells, lower density. So if you lose neurons, you're going to have lower density. And then we can go through this loss of function type of study and basically overlap functional analysis with this histopathological as well as density measurements. And we can see that if you have a lower density, you also have a hearing loss, and the lower density is impacted by the presence of CD4 T cells. So this result, the functional, the histopathology, and density measurement, all of them are consistent with the outcome of a hearing test. And this is my last slide. The cause of Lassa-induced hearing loss is basically correlates with the decrease of spiral ganglion cell density, and it's CD4 T cell dependent. CD8 T cells play a critical role in the acute phase or in the pathogenicity and contribute to morbidity, but have nothing to do with the hearing loss in this particular model. Severe hemorrhagic Lassa fever in Nigeria, in my opinion, is not very common. Outbreaks with max few hundred cases per year, but lethality might be higher than previously reported. And I just want to make sure everybody understands who's going to be designing these studies. There is actually hardcore data. I do have Nigeria data on annual cases, and I can tell you from 1969 through 2021, we're talking about 25,000 total cases. Pretty much it puts you on average on 500 potential cases, 75 confirmed cases, and something less than 25 letalities per year. There are anomalies like the 2018 and 2021. There were outbreaks with over 1,000 cases that year with over 100 letalities. But in general, this is not extremely common, and it's not the major infectious disease priority, at least not in Nigeria. To give you a comparison, I think 2021, you have slightly less than 70 million malaria cases, confirmed cases, and over 195,000 letalities in that country. So this is not even statistically really on their lists in the hospitals. Hearing loss is very common, and likely many cases are caused by previous exposure to Lassa. And I would go back to and echo what Pat was saying. I think you have a better chance of getting, as long as vaccine is safe, certainly. That's my biggest concern. But if the vaccine is safe, I think measuring reduction of hearing loss occurrence in certain areas in Nigeria could be very, very feasible, and could be something that gives you better measurable outcome at the end, especially if you do your trials in the year with very little or very low numbers of the cases. And then vaccine should be safe and prevent severe morbidity as well as hearing loss, in my opinion. And I'll stop here. Happy to answer any questions.
Thank you so much for that really interesting talk. There are two questions from panelists. Well, several questions from panelists. First, Pat Fast, and then Carmen Brewer. If you want to unmute and ask your question, that would be terrific.
Sorry. I lost track of my question here.
Your question was on background
how many?
seropositivity.
I'm sorry. Go ahead.
No, I think you had asked about background seropositivity.
Oh, right. You know, I think this is a problem. It's not really known what the background is. And the reason I ask this question is because 51% for hearing aids and 81% for cochlear implants sounds really high. But what we find in some areas, and what the ENABLE study found, is that the background could be, you know, in the 30 to 50% range, depending on where you are.
Yeah, so around JAWS, we are slightly above 20% is the background. Yes.
Thank you very much.
Dr. Brewer?
One of my questions was, you showed us hair cell data and spiral ganglion data. Did you look at the stria vascularis too?
Yes, we did. And we do have sometimes, we do have sometimes infiltrations there too, and some microhemorrhages. It is very difficult to disconnect that from euthanasia / necropsy and collection of the tissue, because most of these animals are euthanized through CO2 gas, if you want it that way. And sometimes we have vascular leakage and bleeds in various different organs, including in inner ear, which I was never aware of because I never looked at it before. But we do see sometimes microhemorrhage in that area and inflammation.
your spiral ganglion data is interesting because you would expect that if the main damage in the ear is to the fibers of the spiral ganglion, then you would get otoacoustic emissions.
What
Because-
about central area being impacted at the same time?
Pardon me?
What about if the central area in the brain is also impacted?
Otoacoustic emissions should exist independent of central function.
Yeah. No, you.
And see what, ask Tomoko what she thinks. She used to work at NIH, so I know her.
Yes, she knows you. She told me.
And then my other question was just a comment. The CD4 data is really interesting because we see hearing loss in patients with AIDS. And I think we've seen a similar pattern in the spiral ganglion fibers in some of them. Now, there are many causes of hearing loss in patients with AIDS, but it just made me think of AIDS when you were talking about CD4. So maybe there's similarity in the pathophysiology of the hearing loss.
Yeah, Carmen, but he is it opposite. So here, if I get rid of CD4 T cells, I don't have hearing loss.
Okay. I missed that.
This is more similar to, because I used to work on encephalitic viruses, alpha viruses that cause demyelination. This is more similar to EAE. So it's more similar to something that's CD4 T cell driven. That's why I think, at least in this model, is autoimmune driven. However, it is, whenever I ask, when I'm asked, what do I think about mouse model and translation to humans, it's really difficult, as you know, but it is very unlikely, in my opinion, that you take a virus, human isolate, from a country that causes certain disease and hearing loss in humans, you put it in a mouse model, you get the selective destruction of the auditory ganglion. I think it's very unlikely mathematically that there are several different or 1,000 different mechanisms how that can happen. So, and if you put in context that if we completely abrogate the ability to activate T cells with this other knockout, which is on the same background, we get high level of infection, but never hearing loss.
Thank you so much, Dr. Pessler, for that. I apologize that we don't have as much time as we'd like, but I would like to suggest that we cut our break to 5 minutes. So if we can come back at, let's call it 8:15 my time, at quarter after the hour, we can then come back to a summary of what we know about the animal models in our roundtable. Thank you all for your participation. See you in 5. Okay.
The data are not currently available. Wasn't collected.
Pat, I think you're unmuted. All right, it's 15 minutes after the hour. I think we should quickly try and move on. Again, apologies for our delay in getting started this morning. This next session is going to be a summary from Professor Lambert and Professor Pinschuer on what we've learned from the animal models. Please go ahead.
Great, thank you very much. Hi, everybody. Can you move to the next slide, please? So I will start with a few slides just to try and put a perspective on immunopathological disease in viral infection, very general considerations. So the left-hand cartoon is taken from a review by Nobel laureate in immunology, describing the extremes of a spectrum of virus and host balance that I've tried to sketch out on the right side. It shows how T-cell response, viral load, and immunopathological disease are related. And you can see the left side of the spectrum is very good T-cell response, perfect viral load control, so virus very low. The right end of the spectrum is virtually no T-cell control, viral loads very high, and the color in the background is the severity of disease you observe. So disease always ensues when there's substantial viral load, but also significant T-cell response. And there's coexistence of the pathogen and the host response, which keeps fighting against something you cannot really contain. Next slide, please. Okay, so my judgment of Lassa fever is that we're seeing only the left-hand part of the spectrum. The right-hand end of the spectrum is typically seen in human diseases like hepatitis B carriage, but I don't think this is normally observed in Lassa fever. So Lassa fever, if we follow the concepts that Dr. Pessler has put forward and we have also in my lab contributed to, suggest that in the middle of that spectrum where there is a significant T-cell response, but also high viral loads, disease can happen. But really this far end on the right is not normally observed. And on the left half of the spectrum, disease severity seems proportional to the antigen loads in some way, not to say linear proportional, but in some way proportional. Next slide. And as has been illustrated, this can be recapitulated in small animal models such as mice, where wild-type mice normally contain with their T-cell response the infection very efficiently, whereas mice like STAT1 or also IFNAR, interferon type 1 receptor knockout mice, have a hard time containing infection, so viral loads boil up high, and then a T-cell response causes disease. We've done the same with animals that have a human MHC complex. So impaired antiviral defense, innate or adaptive, and resulting impaired viral load control results in disease because the T-cells meet a lot of virus. Next slide, please. And as already shown by Dr. Pessler, and we've done that too, you can deplete T cells, notably CD8s, to prevent acute disease. And thereby you move these mice artificially into an area where I don't think there's a human disease correlate. There's no correlate for this right end of the spectrum, but in the lab we can do it. And of course we can learn a lot about how these mechanisms can operate, but we should keep in mind that this is probably artificial. But then there is one problem here, and I would like to flag this out. Next slide, please. T cell depletion in mice is notoriously transient. This is a graph shown from a publication from Hans-Peter Pircher's lab in 2019. There are countless such reports, and we've seen this in lab too. So T cell depletion prior to infection, that's typically how we do it, and everybody does it, leads to depletion of the cells for 1, 2, maybe 3 weeks, but they come back. So next slide. It means that these animals, they're sent on a journey in my schematic. So they start in the middle, but because T cells depleted transiently, they move out to the right end of the spectrum. So into this high zone tolerance, as it was classically named, spectrum, but then the T cells come back. And it's very hard to predict what these T cells will do. And so I think we should take the T cell pathology as a very likely concept, but we should maybe be careful in how specifically we position the role that T cells and T cell subsets play in the disease context of Lassa fever. And the long-term effect really of this transient depletion can be hard to predict. Keep in mind that CD4 cells are also very important to regulate CD8 cells, besides, of course, antibodies. So there could be effects on antibody immune complex deposition. There will likely be tremendous impact on CD8 responses, which I think everybody agrees in the acute phase of disease play a key role. Next slide. What we and others have observed consistently in these mouse models, now setting aside the depletion experiments, is that vaccination, whereby you move from the central part of the schematic to the left, so in the direction of the wild-type mice, reduces viral loads and thereby prevents immunopathological disease. If there is a direct viral disease, which I'm personally not so convinced, but very possible, this obviously will be also reduced by reducing viral loads, and meaning by vaccination. And I think this is perhaps for today's conversation the most important element to consider, no matter which mechanism of pathogenesis, immunopathological and or direct viral disease, vaccination is likely to move susceptible individuals out of the danger zone, meaning from the center of my schematic to the left. Next one. So with this, I'd like to hand over to Dr. Paul-Henri Lambert for the second part of our presentation.
Thank you, Daniel. I think that we have to consider three main questions. One, can Lassa vaccine prevent SNHL? And what is the role of the direct viral effect versus immunopathology in the pathophysiology of SNHL? Two, is there an increased risk of SNHL after vaccination? That would be bad, but we cannot ignore the question. This could happen through antiviral or through an autoimmune response. And three, can immunological predictors of SNHL be identified through human or animal studies? In other words, what did we learn from human data, disease trial, from small animal model, from non-human primate models, regarding the future investigations that will be required and regarding the data that will have to be collected? Next, please. Regarding human data, briefly, we can say that Favoring a viral etiology of SNHL, you may have the fact that this has been observed in acute disease as well as later, and that there is a viral persistence which has been demonstrated at least in some patients in blood or in tissue. Favoring immunopathology is the fact that SNHL is usually delayed in the survivors, that it is unrelated to the severity of the acute disease, the fact that in survivors, antiviral antibodies, CD4 and CD8 responses can be identified, and that viral antigen, such as soluble GP1, for example, can persist for some time. In addition, we have to keep in mind that so far there is no report of SNHL nor autoimmunity in relation to phase 1 clinical trial. Next. From small animal data, I think that this has been reviewed by Daniel in the mice. I don't think that we have evidence related to a direct viral etiology, although viruses can be detected. But regarding immunopathology, I think that the data which were presented are very convincing, that particularly in relation to SNHL in Lassa infected immunodeficient mice. And in this mice, the inhibition of SNHL when the immune response is blocked is clearly an evidence for immunopathology. It has a significance which is somewhat limited to the fact that we have to use immunodeficient mice for this pattern, but it is sure that interesting information is coming out of the mice. And it's particularly suggesting the usefulness of measuring the antiviral CD4 and CD8 responses in phase 1, phase 2 trials. Next. In NHPs, we have data which are in terms of published data regarding SNHL. We have relatively few publications, and I think that one of the most important one is the one published by the group of Dietrich in cynomolgus monkeys. And there is some argument for a direct viral etiology in the fact that there is a viral persistence and virus could be identified in the inner ear vasculitis, which is appearing in some of the survivors. Unfortunately, in this study, there were only 10 monkeys infected and 3 survivors, and at least 2 of the 3 show viruses which persist. But a lot is coming in favor of immunopathology. There is an antiviral immune response which is detected in survivors. And there is, and this is the main feature, a systemic vasculitis which has been identified in these survivors, which is very similar to polyarteritis nodosa, PAN. And this is seen particularly in the inner ear, where a vasculitis can be seen. And there is a picture, in fact, on the slide, which looks like all red, showing quite an intense vasculitis. And in this particular case, a viral antigen was detected up to 45 days post-infection in this vasculitis lesion. And the question is open as well for autoimmunity, since anti-neutrophil cytoplasmic antibodies were detected in 1, possibly 2 of the 3 surviving primates. Next. So I would conclude from what we have seen there in animal, but also with the human story, that first, SNHL in the survivors is likely to involve immunopathology, possibly linked to viral antigen persistence, but a direct viral effect cannot be excluded. Two, that small immunocompromised animal models are certainly of interest to explore the pathophysiology of SNHL, but they are unlikely to provide a relevant assessment of the risk of SNHL after vaccination. Three, non-human primates appear as relevant models to assess the vaccine impact on the occurrence of SNHL after exposure to LASV. And from what we have seen so far in NHPs, vaccination with some candidates result in a strong reduction of the viral burden and in a rapid viral clearance. This is likely to reduce the risk of virus-related immunopathology as well as of direct viral effect. Next. And therefore, introducing the following discussion, I would say which investigation or data will be needed. And here we have data from human, data from animal experiments. We could say that most studies of innate and adaptive immunity should be done in Lassa survivors to identify the potential biomarkers of SNHL and related pathophysiological pathways, and this may include transcriptomic studies. In vaccinated NHPs, the monitoring should be extended enough, possibly up to 2 months, to assess the vaccine impact on the post-challenge occurrence of SNHL, and this should, if possible, include audiometric investigation, maybe by telemetric mechanism, and as well as autoimmune biomarkers such as ANCA. In view of the limited availability of these primates, the potential value of guinea pig Lassa model should be further assessed, and this has been used, in fact, by the groups in UK. And for human trials, I think that early and delayed monitoring of autoimmune biomarkers and, when feasible, a comprehensive assessment of the magnitude, but also of the differentiation of virus-specific CD8 and CD4 T cells should be considered. We may also collect blood for a potential analysis in a second time of transcriptomic changes. Thank you.
Thank you so much, Professor Lambert and Professor Pincher. I'm going to turn this over now to my colleague, Steve Black, who will be the moderator for our panel discussion. And just as a brief announcement, unfortunately, Nick Reed has had to excuse himself and will not be available for the panel due to a family illness. Steve, over to you.
Okay, thank you. And thank you all for listening. What we're going to do now is try and address 3 questions, and I'll briefly summarize them before going through one-on-one, asking the panelists to comment. The first question is what hearing testing should be done at screening, whether this should be done at all versus a subset, and what are the logistics of doing this in a large phase 2b/3 trial. The second question relates what testing should be done in individuals who are identified in a clinical trial as having sensorineural hearing loss to better delineate the pathophysiology. And then similarly for animal models, what further testing should be done to look at possible vaccine association. So for the first question, what hearing testing should be done at screening? Who should it be done on to identify sensorineural hearing loss that might occur in a large phase 2b/3 trial? I will ask maybe Carmen Brewer to start the discussion here, if you would, please.
Okay, could you, Claire, thank you. And thanks to all the presenters. This was a really interesting session today. When you refer to screening, do you mean screening for eligibility to participate in the trial, or do you mean a baseline hearing test? Just to clarify.
Not for eligibility. I think that's a separate question. I think what we're asking is
Baseline hearing test.
baseline and what baseline hearing test and what follow-up testing should be done in large phase 2B and 3 trials.
I hate to not give you a "this is what you should do" answer, but I think it is somewhat dependent on what you find in the 2A trials. So if you have no evidence of anyone developing a hearing loss after vaccination, and this is with monitoring out to 4 months, I don't see that you have an argument to test everybody in a phase 2B trial.
So that begs the question of who you would test then and when.
I'm a believer in the baseline test, number one. And then a follow-up test. And who would I test? I think you could do a random subsample. And there's no evidence to say this particular group should be tested or not, unless you find something on biomarkers that makes you think one person is more susceptible than the other.
Okay, so maybe I could ask Paul Uller from SPEAC to comment on your thinking on this so far. Paul?
Yeah, thank you, Steve. Yeah, I think it would be good, considering numbers that would be included in a phase 2B or a phase 3 trial. I think it would be good to consider doing an audiometry testing within a subset. I think we've heard from quite a number of presentations on issues to do with logistics around turning around testing, specifically for studies with large numbers of participants or subjects. And I would also perhaps also think about follow-up testing as well, in terms of really how would this testing as well be included in a diagnostic workup, for example? I think that would also be important. So we are looking at perhaps having repeat audiometry testing for those who test positive for Lassa, depending on the case definition as well. And of course, having a case adjudication committee as well, pick up these cases. So I would, think of a subset of subjects as well for this specific testing.
So at FAST, you proposed using hearing loss as an effectiveness outcome as well in the trial. What are your thoughts about who should be tested, who should be tested at baseline and follow-up testing?
Yeah, thank you for asking. I'm very reluctant in the absence of any kind of numbers right now to say that we would test later but not have a baseline. That concerns me a lot, because if you have small numbers, then you could easily have a random allocation and you could get the wrong answer one way or the other. If we had an estimate of how many people might develop hearing loss during a trial, just because from epidemiology, then I think it would be a lot easier to make that call. to not do baselines. I definitely do think that at some point, and we are hoping to do this in our phase 2B trial, there should be some kind of a nested case control study or something to make sure that people who to determine whether there's a larger chance if you become seropositive of losing your hearing without necessarily suffering from Lassa fever. I mean, even if that could be done in an epidemiologic study, it would be preferable. You know, it's hard to do your epidemiology as part of your trial, although control groups for clinical trials are always a great source for epidemiology. But I think the minimum is, for me, the minimum at this moment, in the absence of any information about how frequently hearing loss develops, would be that we'd need to have baselines, because otherwise people would crop up during the trial saying that they had lost hearing, and they might in fact be hard of hearing or have very poor hearing, but we wouldn't know whether that was pre-existing or not. So that's a source of concern.
Dr. Okobenin, do you think you could comment?
Thank you. I think I'll be a bit more specific. I think it's really important that we check for sensorineural hearing loss, at least in the 2A and 2B. I would say because of the complexity of doing the test, perhaps in a subset, I'll agree with Paul on that. If we can have baseline for a subset, and then we can thereafter check at different intervals to see if there's any sensorineural hearing loss. Then for the 2B, I think May did say that they would do a baseline for everybody, and then anyone who complains of deafness will now have a second test. But I would also have want that anyone who tests positive, because in the trial there will be both the controls and the ones with the active vaccines who really want to know who is getting what. So anyone who tests positive for Lassa would have should also have another hearing test being done. But a subset will be very important, and because the subset will tell us those who are infected without showing any disease, and so we can also know if there's hearing loss in those who haven't shown any symptoms. So I think a hearing loss for the subset, and I'll probably go for a pure tone audiometry at different frequencies, like we discussed. Over, thanks.
Okay, Dr. Blackie, would you like to add to that?
Yes, I would want to agree with Professor Kogbeni that a hearing assessment should be done for those that are these phase 2B, that subset should have a hearing assessment done. But then again, I would want to say that if somebody probably that has a baseline hearing assessment comes down with hearing loss, would it be okay to do something like a complete audiological assessment at that point to know exactly what is really going on? Because I mean, like we see, not everybody may come down with hearing loss. Not everybody that is infected will have hearing loss. And then again, hearing losses are varied. It could be unilateral, it could be bilateral. However, bilateral hearing losses are more. So I would think that the subset is important. We do an assessment. Then if we find anybody that has hearing loss, we should do something like a complete audiological assessment.
So thank you. That's a good segue actually to the next question.
What additional? First, I'm sorry. If you haven't done pediatric patients yet, they all should get a hearing test.
Yes.
That's because a hearing loss is going to have a much bigger impact on them. And until it's proven that in the pediatric group, they should all have tests.
Okay, thank you. So
If I can just say, for at least for the IAVI 2A study, which is coming up, we will be doing it systematically in the children. It's a
Right.
relatively small number, but we will do that.
Right.
thank you. So to move on to the next question, what additional, assuming we figured out the answer to the first question, and you identify individuals in the trial with sensorineural hearing loss, what testing should be done on them to delineate pathophysiology and possible vaccine associations? So, Paul-Henri, you started to give us guidance in that regard. Could I ask you to expand on that, please?
Yes, I think that it would be very useful if it can be done. We know it's not always easy, but to get some ideas about the T-cell response in these people with not just T-cells, but virus-specific T-cell responses, and looking in detail at the differentiation of these cells. This could be done for malaria, so it may be feasible, at least in some sites. And I think that regarding other potential mechanisms, autoimmunity, I don't think, frankly, that autoimmunity will be the major problem there with the vaccine with one single antigen, but we cannot exclude that, and therefore at least collect blood and do autoimmune markers analysis would be useful.
So that obviously has implications for infrastructure where the trials will be conducted. Dr. Pessler, did you want to expand on that?
Yeah, maybe two little things. One step back. First of all, with relating to malaria per se, I think it's important. That's what we've seen in JAWS. Sometimes people don't tell you what anti-malaria drugs they already took before they showed up. And many of these anti-malaria drugs themselves can have impact on hearing. Yes, it's transient, but it can actually screw up your data and look worse than it truly is. The other thing is, and I do understand how difficult it is to design clinical trial, but I want to tell you my working hypothesis, and it is just a hypothesis, but I think data is pointing that direction. My working hypothesis is that it's molecular mimicry, and it is linked to NP antigen. So first of all, it's good the vaccine doesn't have the NP, at least from my perspective. What you generate is you generate auto-reactive either antibodies or CD4 T cells. We don't know that yet. And it is not easy to get them into immunoprivileged organs such as auditory nerve, actually. So there might be a trigger, because don't forget, currently major number of Lassa-related hearing losses from those people that don't even know they had Lassa. So most number, this is like a pyramid, okay? So 98% of Lassa cases are never symptomatic enough for people to go to hospital. So if that's the case, I'm trying to think, what group can you include in your trial? So who is at risk? In my opinion, that would be good. Who is at risk of, in the next few months or half a year, to get some kind of bacterial ear infection or anything that would trigger inflammation in that inner ear, and actually now allow these autoimmunoreactive T cells / antibodies, whatever it is, to penetrate the inner ear. Because I think it's not just, the trial's not going to last forever. And it's not just about, does the vaccine cause directly hearing loss? The question is also, does the vaccine make you at the high risk of developing hearing loss down the path, especially if you're a young vaccinee? And on the other hand, if you can get the data and obtain the data that you really protect against hearing loss, so if you reduce hearing loss in certain area, that would be beautiful. And the last thought, just for Pat, I know people try to avoid talking about this, but there are a bunch of other arenaviruses circulating in all of these areas, and the NP cross-reactivity is huge. So I'm not even sure if all of those NP seropositives are truly Lassa only. And I'll stop here.
Okay, thank you. Karina, Pop from INCEST, do you want to add to this discussion before?
Yeah, thanks, Steve. It's been a really interesting discussion. I think, from INCEST, for International Network of Special Immunization Services, our focus has been on, or is on, applying systems biology multi-omics approaches to understanding pathophysiology. And I think there's a lot of important work that needs to be done around understanding the immunology, immunopathology of this hearing loss. But and so as an adjunct to that, I'd suggest collecting additional specimens that could be used for multi-omic studies. So like whole blood that can be fractionated for plasma, serum, cells, and PBMCs to support these to be able to do proteomics, metabolomics, transcriptomics, and integrate those with the immunology readouts. And I think so those, we'd want to collect around the time of the onset of hearing losses, if it's sudden onset hearing loss, and then at follow-up time points, for example, 3, 6, maybe even 12 months, depending on the length of the study. But in order to be able to compare those results, it's also important to have controls. And so in a study like this, especially where there's baseline hearing assessments happening, to have a subset of, a safety cohort or something, a subset of clinical trial participants that undergo prospective blood sampling, as well as potentially saliva from controls, as well as cases for genomics or metabolomics, proteomics as well. That's easy to collect, so that you at least have the samples collected prospectively during the study. And then if you do see cases of sensorineural hearing loss, then you have controls to compare those cases to be able to interpret what you're finding. And I think, in addition to these cases that emerge, of course, it's going to be important to try to assess the likelihood of a causal association with the vaccine. So trying to exclude other causes, looking at Lassa fever, seroconversion may be complicated by the vaccine, but trying to exclude other causes was mentioned, if there's other drug exposures or infections that could have also contributed to the hearing loss.
I think we'll move on to the third question.
May I say something? Sorry. To this one. I think it's interesting, the proposal of Dr. Pessler, that we might have a mimicry setting. If this is a hypothesis to test, then it would be important for at least those showing some anti-nucleoprotein antibodies. I'm completely on board that the specificity for Lassa is hard to define. To have maybe a ratio or so of glycoprotein versus nucleoprotein antibodies determined, because the vaccine is likely to influence this. And my expectation would be that besides lowering viral loads that might attenuate T-cell responses, it would give an antibody shift towards glycoprotein, which is in the vaccine, as opposed to nucleoprotein, which in the formulated hypothesis would be the target of an autoreactive or autocross-reactive response. That could help. I should add that in all animal models of arenavirus infection that I know, and I've worked with several of them, the arenavirus-induced T cells are very, very, very able to invade the central nervous system and cause disease. So I think this should be seen in all wild-type animals in these studies that don't show the disease, if it were simply a T cell response to NP. But of course, that remains to be tested. Thank you.
So maybe moving to the third question, and ask you maybe to lead off on the response to that. What animal studies should be done to better understand the pathophysiology or a possible vaccine association?
Can I start, Steve? I think that what we have seen so far is that a number of vaccination has been done in non-human primates with challenge, but usually the follow-up is relatively short. And for very practical reason is that it's not so easy to keep these animals in BSL-4 and to do extensive studies. But I think that everything should be done to look for the occurrence or not of SNHL in vaccinated cynomolgus monkeys. I think that this would be extremely worthwhile if we can show that vaccination, by decreasing the viral load, is also able to prevent completely the occurrence of SNHL. But for that, you need models for which monitoring is really possible in this particular condition. And this may require telemetric system of different kinds.
Okay, thank you, Paul and Ree. Would any of the other panelists like to comment? Or others from the audience or perhaps would want to comment? If you can let us know in the questions, we can try and address a couple of those.
Well, maybe it's Sylvanus. Animal studies, I would just have thought it in a simpler way. What if we want to see if the vaccines themselves can cause sensorineural hearing loss, is to really test the vaccines on the animals without the Lassa challenge, and then watch them over a period of time and see if we can even see the ear changes, the cochlear changes that have been seen with those who have had Lassa challenge. Perhaps that could give us some insight as to what the vaccines can also do to the hearing in animal models. I thought I'd make that.
Can somebody explain to me, I seem to be naive, but why should the vaccine in the absence of Lassa virus exposure cause hearing loss?
Yeah, because it's just a fear amongst the vaccine developers who are going to try the vaccines in the population. We need evidence to say, look, the vaccine does not cause, like in the phase 1 study done by IAVI, I think it was documented that the vaccine does not cause hearing loss in humans for the phase 1 study. So if there's still a fear that the vaccine could cause hearing loss, and we've heard so much about the animal models, with Lassa fever causing hearing difficulties in animal models, then we probably need to also state that the vaccine does not cause hearing loss or hearing defect in animals. In the early phase human study, it still does not cause hearing loss. Then it's more, there's more confidence in that vaccine that this will not be causing hearing loss in larger studies, in larger phase 2, phase 3 studies.
Okay, thank you. But is there animal data or data that would suggest, or is there a positive mechanism that would predict that the vaccine could cause what Lassa virus can cause?
Can I try to answer?
Please say that again.
Pardon?
Mm-hmm.
Someone else
I
was
didn't
trying
get
to. Yeah.
I don't think he heard you.
I think.
Did you say that again? I didn't hear that very well.
Oh,
he was asking whether there's any evidence that vaccine could cause hearing loss pathology, either in animals or people. And I think the answer to that so far is no. But the important part of that is the so far part. We have data on 100 or so people in phase 1 studies, but that does not rule out a rarer possibility of causing that. I think we're going to have to move on. We're almost out of time here, and I want to give time for Rebecca Chandler from SEPI to make a final closing remark. But before I do that, I want to thank all the speakers and the panelists for your participation in this webinar today. Rebecca, please.
Thank you, Steve. And I just want to thanks to all of our participants, our presenters, as well as our audience. I really hope that this is the beginning of something new for vaccine safety in a way. I really am thrilled that through the SPEAC project that CEPI has been able to offer a platform for our developers as well as researchers in the area and multidisciplinary discussion to see how we can translate mouse models and immunology studies into our clinical development programs, and our case definitions for safety endpoints. So I hope that we can have further discussions. I hope we have made some connections. I see a question that's popped up from Carmen about what is the planned follow-up to this session. And I think that's, since this is our first time doing something like this, I think that's up for discussion, actually. Maybe we should, just in the interest of time, we've all been here quite a while, I would welcome some input. You could write to Maria, who I believe sent the invitation, and I don't know if that's maybe we do that and we'll follow up. We'll have a recording. I think it would be also a very good idea for us to write this session up. So maybe we will be in contact with the next steps. But please, we're open to suggestions. And again, thanks to everyone for being here today, and we really appreciate the input and the rich discussion that we've had thus far.